I finished my PhD in 2011, left here in 2012, went to Black Dog Institute. My PhD kind of looked tangentially at suicide as an outcome for opioid-dependent people, but I can't say I knew an awful lot about it. I still refer a lot to Shane's research on suicide by overdose, so lots of work that you've done in this area has been really fascinating. And when I joined Black Dog, there was about 45 people there. We're now up to about 160, and it feels like there's 1,000 projects going on at any one time. So it's a pretty exciting place to be, but also a slightly overwhelming place to be sometimes. And I know NDARC went through a pretty rapid growth phase as well back in the day, and it feels a bit similar actually. So yeah. So in terms of suicide research, I mean, I think compared to drug and alcohol, it's actually a fairly new field. So having been to all the APSAD conferences over the years and other drug and alcohol conferences, I turned up in 2013 to my first National Suicide Prevention Conference expecting something similar in terms of the science, and it was a very different experience. Gab, you've been, yeah? So it's much more about lived experience, it's less scientifically based, the research base isn't as strong as it is in drug and alcohol. A lot of the research in suicide is around the epidemiology, risk factors, et cetera, but there's a lot less research in terms of what actually works to prevent suicide and to reduce suicide at a population level. And you know, the national conference I think has evolved over the years, so it is more science-based now, but I still think the evidence base has a long way to go. So yeah, so I will kick on. Let me just find my clicker. Thank you. Okay, so what am I going to cover? So I want to just paint a bit of a picture of where suicide deaths and attempts are in Australia at the moment and what they've looked like historically, to have a look at a little bit at what some of the risk factors are, and then to have a look at a couple of the contemporary models of suicidal behaviour which have some fairly good research behind them. They've emerged in the last probably 10 years or so. I then want to move on to have a look at what does the evidence say about what works in suicide prevention. So what do we know? Really hard to do intervention research in suicide. Ethics committees get a little bit scared when you talk about measuring suicide as an outcome amongst high-risk populations, but nevertheless it gets done. And then to look at work that's happened overseas in terms of whole of community approaches to suicide prevention, but also look at what's happening here in Australia with some of the research we're doing coming out of the Black Dog as well as elsewhere on what we call multi-level models of suicide prevention. So, that's doing something funky that I didn't predict. Let's see if we can get it to move on. Or I could just stay on this. Here we go. Okay, so that's what happens when you use a previous presentation and copy over top of it, Shane. So, last year, 2017, we saw quite a big increase in the number of suicide deaths in Australia. It was about, I think from memory, it was 3,128. That's not finalised yet. That'll happen in due course. But that was quite a big increase on the previous year. And what we've seen over the last decade is a gradual climb in suicide deaths in Australia. So at the moment it's sitting around 12.7 per 100,000. In the period 2007 to 2011 it was sitting around 10.6. What happened in Australia was around mid to late 90s it peaked, and that peak was driven by young men. And we think what we're seeing is that cohort of men actually moving through the years. So now the most at-risk group is men in their 40s and 50s in terms of suicide deaths. So obviously some economic and social factors feeding into that particular group being at risk. So it did come down for a while after that, but now it's on the climb again. So 75% of suicide deaths occur amongst men, but 2/3 of hospitalisations for self-harm occur amongst women. And Shane and I were talking about this before. There's a men's movement out there which talks about we're not doing enough in men's suicide. I would argue we're not doing enough in suicide generally. I don't think it's gender specific. And in fact, some of the research I'll show you later shows that it's more effective for men than it is for women when we use particular strategies. Now, some of those hospitalisations will be non-suicidal self-injury, but a large proportion of them there'll be some suicidal intent there. Part of the reason for that disparity between attempts and deaths across the genders is that women tend to use less lethal means of suicide, so when they attempt, they're less likely to die than men. But that doesn't, there's no evidence to show that the intent is any less amongst women than it is amongst men. So 85 plus is the age group with the highest rates per 100,000. They're a fairly small population because, you know, the life expectancy is somewhat less than that. So in terms of absolute numbers, but also highest rates, the group that it really is of interest is those people in their mid-40s to 50s. And as I said, men in particular in that group are at risk. So for the first time earlier this year, the ABS started to dig into the coronial data to try and identify what are some of the comorbid factors that they're picking up through the coronial data. This is imperfect data, as any of you who've worked with the coronial data will know. It's reliant on non-standardised text reports from police, other professionals who don't report in a particularly standardised way. But they did find that, I think it was about 80% of suicide deaths had some indication that there was a comorbid problem going on. So what they found was about 43% there was evidence of a mood disorder, including depression, obviously bipolar disorder. Around 30% had a drug and alcohol use disorder, 17% anxiety, and about 15% had alcohol and other drugs in their blood at the time of their death. So again, if you look at the international literature, the figures in terms of alcohol involvement in suicide deaths tend to be around that 35 to 40%. So it's a significant contribution. It's a contributing factor to the person becoming suicidal, but sometimes people will also use it as a way of working up the courage to take their own life. But also, it can also mean that people reach that crisis point because the alcohol is affecting their ability to impede kind of impulsivity. So the other thing they did was to have a look at the top psychosocial risk factors by age group, and I've tried to present a bit of a summary of that here. So if we look at this group, history of self-harm or a previous suicide attempt is still the strongest predictor of death by suicide, and that's been the case over many years, but it's particularly the case in the younger age group, under 34 years. Family disruption, separation and divorce was the case for all people under the age of 65, especially men. And again, if we look at the research on men and suicidality, we know that family breakdown is a particularly big risk factor, a big trigger for men, more so than a risk factor. Relationship problems with their spouse or partner, again, more significant for those under 45 years. Bullying for younger people. Limitations in activity caused to chronic health conditions was not unsurprisingly amongst older people. This was interesting, death or disappearance of a family member or a primary support group. So that could be not just the disappearance of a family member, but the loss of social support. And that was prevalent amongst people in the over 35-year age group, and changes in economic circumstances was particularly prevalent for men 45 to 64. And again, we find that loss of status is a big risk factor for men. So I don't want to spend too much more time labouring on risk factors, triggers and warning signs, but this is kind of a bit of a heads up to some of the stuff that we'll be covering. So as I said, previous suicide attempt, exposure to suicide, so that might be that they've lost someone to suicide, they've cared for someone who's had suicidality, or it can be exposure through the media, and I'll come back to that. Mental illness, and again we know that mental illness is often but not always present in people who die by suicide, and also that a lot of people who have mental illness don't contemplate suicide, let alone attempt it. Substance use disorders are very prevalent, obviously history of trauma, family breakdown and dysfunction. Access to means, so the greater the access to the means of suicide, the higher the rates of suicide at a population level. And again, we'll come back to that as an effective prevention strategy. Chronic health problems. One of the areas that we're starting to get a bit more interested in at Black Dog is this whole area of policy levers. So there's some research around lower access to treatment, greater access to means, increases in unemployment, particularly where that's coupled with lack of unemployment support, so either financial support or return to work programs. And there's also a little bit of evidence around inequality in terms of rights. So if we look at the gay marriage debate that took place last year, there was some evidence coming out of other countries that where LGBTQI plus populations have greater rights and greater acceptance, we see a decrease in suicide attempts. And again, income disparity at a whole of country level seems to impact on things. I'm not going to dwell on the warning signs, except to touch on thoughts of burdensomeness, thought of belongingness and feeling trapped are part of one of the models that I'm about to show you. Yeah, so I'll flick onto that actually. So there are really two plus a third model that are emerging as the most well-known models in suicidal behaviour. The first one is by Kim Van Orden and Thomas Joyner, and it's the interpersonal psychological theory of suicidal behaviour. And what it theorises is that if you have this sense of being alone, so this lack of belonging, lack of connection, combined with this belief that I'm a burden on the people around me, where that combines, you get this suicidal thinking, so this desire for suicide. And again, there's a fair bit of research that actually supports that. And certainly, if you talk to clinicians, those are the kinds of thoughts that people will often express in conjunction with suicidal thinking. But what's really interesting, and Gab's done some work on this actually in the chronic pain population, in the POINT study, is there's this group of people who will think about suicide but won't attempt. And then there's another group which will actually make that transition to a suicide attempt. And what we're less good at is predicting who's going to move from suicidal thinking into making an attempt. So again, risk prediction is a bit of a controversial area in care of people who are experiencing suicidal risk because we're not very good at it. So lots of studies showing that you know, when people get triaged, often it's the people who get triaged. There's not much difference between people who get triaged as low risk versus high risk in terms of the proportions of people who will die by suicide. There is a bit of work going on around big data, looking at can you pull big medical hospital data sets together and do some risk prediction around that, and that's looking promising. But at the moment, a lot of the clinical tools that we use, a lot of the risk prediction factors that we use are not very helpful in terms of predicting which individuals. They are good at identifying groups of people who are at risk, but not the person who will go on to make an attempt. So this is an attempt to try and get around that, and it's kind of starting to get there, but it's still not great. So what Joyner and Van Orden have called this is acquired capability. Again, there's some research that shows that there is a genetic component to this. It's a type of fearlessness about pain and death, and that can come about through genetic risk, but it can also be through exposure to violence and trauma, whether that's personally or vicariously. So again, we see fairly high levels of acquired capability amongst emergency service workers who are working with trauma day in, day out. This model looks much more complicated, but I actually like it. So this is Rory O'Connor's model, and it's got such a long name, the Integrated Motivational Volitional Model of Suicidal Behaviour. And it kind of builds on Van Orden and Joyner's model in that it, that it actually takes into account the thought of belongingness, the burdensomeness, as well as this transition. So these kinds of things here would be the kinds of things you'd be looking at with acquired capability. But it builds on it to say, so what are some of the background factors and triggering factors that would push someone over into this thinking about suicide? And so they talk about the environmental factors as well as the life events, but then that people experience defeat and humiliation, they feel trapped in that situation. And again, lots of research has shown that this concept of entrapment is a pretty good predictor of suicidal thinking, which creates suicidal intent, and there is these various moderators along the way, both those factors that protect as well as those factors that increase risk. You can see here that they kind of encapsulate this acquired capability as being access to means, exposure to suicide, impulsivity, physical pain sensitivity or lack thereof, fearlessness about death, imagery and past behaviour. Yes. Oh, so Yeah, I don't actually, it's kind of like, they talk about the diathesis stress model, so I think that's more the internal risk factors that people are experiencing, but other people might correct me if I've got that wrong.
We just Googled it.
Yes, good.
And just going to Google definition of attendance and decide from a particular commission. So like
Yeah. Yes. Okay. Yeah. So I always have trouble because it's such a complicated word, and I think, oh. Okay. So we've started having a bit of a look at doing some systematic reviews. We've got one that's in submission at the moment, another one under preparation, at the policy areas in suicide prevention, because there is a limit to what a region or an organisation can do. So when we look at the estimates of what good suicide prevention on the ground can do, it's probably around a 20% reduction in suicide deaths. That leaves 80% of people who are still at risk. And what we don't know is what is the contribution of various policies to suicide. So we're starting to have a bit of a look at that. So we had just a general kind of rough search of the literature to have a look at what the areas might be that we want to dive into. And you can see up on the right here some of the different policy areas where we found some papers which seems to suggest that they might be worth having a bit of a dive into. So access to treatment, there's some good evidence that if you increase access to both psychological treatment as well as medication, that you see a decrease in suicides. Access to alcohol and alcohol policy, there's a lot of literature in that area. I mentioned LGBTI rights before. Employment and welfare is really interesting. So again, some research coming out around the global financial crisis, where what they found was that in all countries when unemployment went up, suicide also went up, but in countries that had the good social support systems in place, that effect was dampened a bit. So you look like you want to ask a question, or you're just interested. Feel free to ask on the way through. Immigration policy, immigration and asylum seeker policy. There was nothing to show any association with medical marijuana. The austerity policies in Greece and other countries seem to have an impact in the negative direction. Domestic violence policies and justice and detention policies. So I've just put a few examples up there. So increasing antidepressant sales and increasing density of psychotherapists, both associated with a decreasing suicide rate. The systematic review that I've talked about. Some of the alcohol research, so per capita increases in alcohol consumption seem to increase suicide rates in time-lag models. Changes in legal drinking age associated with changes in suicide rates amongst young people. And again, one of the earlier studies from Danita Wasserman around a naturalistic study in the USSR where they restricted sales of alcohol there in the 1980s and found very significant declines in suicides, especially amongst men, something in the order of 34%. So it was massive. Shane, you're nodding, so you've obviously heard of that before. Yeah. So, so the role of alcohol, I think, can't be underestimated in suicide prevention. And has a great relevance at the moment with the lockdown laws. So, yeah. Oh, yes. Yes, yeah, there is actually. So, again, in the US, we see that it's not great quality research because in Australia, for example, when they had the gun buyback, we saw a decrease in suicide deaths. So there's that. I don't know that much was published about that, but certainly in the US, when we look at the means of suicide, the percentage of deaths by gun and suicide by gun in the US are massive compared to other countries. So it's not that strong. But yeah, it's definitely, there's a signal. Rebecca.
The justice detention, can you explain what that effect was? What they did?
Yeah, I'd have to go back and have a look at the papers that we dug up to give you any useful detail about that. So happy to email you. Yeah. Okay. All right. So. Moving on to what does the evidence say about effective suicide prevention. So there was a big systematic review by John Mann back in 2005, and then there was an update to that in 2016 by Gil Salzman and his colleagues. And they reviewed all of the suicide prevention strategies that they could possibly think of. And pleasing to see that some things have been added to the list in terms of what works. So back in 2005, Mann et al. Found good evidence for restricting access to means. I don't know how many people know what gatekeeper training is, but effectively what it is training for community members to recognise and respond to signs of distress or suicidality amongst friends, family members, colleagues. Educating general practitioners in how to recognise and manage suicidality. There are some psychological therapies that seem to, that are directly aimed at suicidality that seem to be effective. So CBT, DBT, particularly for people with borderline personality disorder, problem-solving therapy. And the other area of work that's really ramped up in the last 10 years is in the area of responding to people who've already made a suicide attempt, because again, they're a very at-risk population. And intensive aftercare, assertive aftercare, where it's the care provider who's responsible for maintaining connection, seems to make a difference in that area. Mann at the time said that there wasn't enough evidence to support public education and campaigns, broad-based screening either in schools or in primary care, or indeed for media reporting and media education. In 2016, more evidence for means restriction. So in the UK, there was some work around changing pack sizes for analgesics, and there's been quite a bit of research on the impact of that on suicide. And changing common jumping sites, so putting in barriers to make it more difficult, landscaping so you increase the amenity of the area so there's more people going through the area. There are locations around Sydney where they've actually got CCTV so first responders can get there quickly. So on and so forth, putting up help-seeking signs as well as phones so people can contact Lifeline. And what we find is that surprisingly there isn't that much substitution of means that goes on. So when people are in crisis, they tend to have a particular plan in mind, and if that gets thwarted and there's an opportunity to provide support, then we can actually see people make recovery. That's not going to be all people, so there are some people who obviously live with chronic suicidality. But for a large majority of people, means restriction seems to be an effective strategy. School education programs, I'll come back to what that looks like. Lithium for people with mood disorders, clozapine for people with psychotic disorders. Ketamine seems to have some promise but is fairly short-lived in its effect, so there's lots of trials going on at the moment about how do you best administer that, how is it best managed, what kind of dose do you need to provide. Again, GP education coming up has been quite strong. And also, both pharmacological and psychological treatment for depression as a risk factor for suicide. And again, what we see in both face-to-face trials and also online trials is that, on trials of online treatment, is that the trajectories are a bit different. You'll see changes in symptoms of depression will change more slowly than changes in suicidality, but nevertheless, we do see reductions in suicidal thinking when we treat depression. And in fact, when we treat insomnia, so an online treatment for insomnia also saw reductions in suicidal thinking. So there's some really promising work going on. Again, further research they identified was public campaigns, screening. We know it's not harmful, so it doesn't hurt to ask people about whether they're thinking about suicide, but we also don't know what the benefits are. Media education, and then there's some work going on around social support strategies. So if you can increase people's social support network, their social connection, we don't quite know how that's all working out at this stage. The other things I wanted to mention, so Michelle Torrick, who also did her PhD here with Shane, is now working with us at Black Dog Institute. So she led a paper looking at public campaigns and did a systematic review of those. And the only evidence we could find is that when it's part of a multi-level model, so it directs people to help seeking, for example, then it might be helpful, but otherwise not. There are a number of high school programs, so these come out of both Europe and the US. Youth Aware of Mental Health is the one we're using here in Australia at the moment. Signs of Suicide, Sources of Strength. And again, randomised controlled trials showing that you can get reductions in suicidal thinking and suicidal behaviour amongst high school students if you use these programs. I think the longest follow-up has been about 12 months at this stage. Good Behaviour Game is a primary school-based program, and it's not curriculum-based. It's basically behaviour management and tweaking social networks. So you take kids who have more acting out, kind of externalising behaviours. You mix them up with kids who are more pro-social, I suppose, and there is a theory that it's actually the changing those social networks that encourages more pro-social behaviours, reduces, in a 17-year follow-up, reduced alcohol and drug use, reduced criminal behaviour, and also reduced risk of suicidal behaviour. So really interesting. They're doing this work in 5 and 6-year-olds. So really simple behaviour management strategy. Michelle Torrick is also doing some work on that in Australia. She's doing some amazing stuff. And we're seeing these results several years down the track. I'll come back to the media reporting. So there's some good evidence emerging in that space. For adolescents, multi-systemic and family therapy, training first responders, and also so safety planning. There was a trial of, I don't know how many people have heard of safety planning, but it's a way of getting the person to step through what are my warning signs, how do I reduce my access to means, how do I get support. There's a number of steps involved in it. And again, they did a randomised control trial comparing that to the no suicide contract, and safety planning was the clear winner. So we don't recommend no suicide contracts anymore. They don't work, but safety planning seems to help.
So, quickly,
Yes.
Are You OK campaign, which has been criticised for being quite populist and without substance.
Yeah.
Is there any evidence of effect either one way or the other?
No, is the short answer. Yeah, so where you have campaigns like Are You OK, and you link it into, you know, if you want to help, here's a way you can do gatekeeper training. We think that might be helpful, but the evidence is still a bit sketchy. Yeah. So, I have to say it's hard to evaluate the exception to that would be Jane Purkis's work with Gus Warland. It was a program aimed at men where Gus Warland went around and he spoke to male students, and they did a randomised controlled trial of that, and what they did actually find was not changes in suicide risk, but changes in help-seeking behaviour. Yeah, so addressing kind of those masculine norms. So yeah, and Jane Purkis's group has also done some work around masculine characteristics, and what she's finding is that I'm trying to think of the right term. It's not stoicism. It's excessive self-reliance is actually a risk factor for suicide attempts in men. So that idea that I can fix everything myself, I don't have to ask for help, is a risk factor. So, summing that all up, hopefully somewhat neatly, I've tried to kind of group these into universal, selective and indicated prevention strategies. So universal being whole of population approaches, whether it's a whole of community or a whole of a school or whole of country. Means restriction, community campaigns where it's embedded in a broader framework. School programs targeting the whole school population. So these programs don't just target at-risk students, they target all students within a particular year group. Media education. The selective strategies, so GP education for treating people who have depression, anxiety, suicidality. Access to quality treatment. Training first responders and gatekeeper training. And then indicators, so this is a group of people who will already be experiencing a suicidal crisis. Intensive aftercare, psychological treatments, pharmacotherapies to some extent, and the safety planning. So there's bits and pieces emerging as being useful. I want to move on now to the work that we're doing here in Australia. And I will talk a little bit about the media stuff in there actually. I'm just going to get my glasses out so I can read. Just got a few notes I want to make sure I don't miss things. Okay, so this is an area of research that's been going on since the early 2000s, and we talk about multi-level models or multi-sector models or multi-strategy models of suicide prevention. And really what we're talking about is within a region the simultaneous implementation of multiple strategies in order to reduce suicidal behaviours. And the work started in Europe back in the early 2000s. This wheel I will come back to. This is our strategy, our framework that we're implementing in New South Wales and elsewhere at the moment. And I just want to step through the evidence. So the Salzman systematic review that I put up before, it concluded with the comment that in the quest for effective suicide prevention initiatives, no single strategy clearly stands above the others. Combinations of evidence-based strategies at the individual level and the population level should be assessed with robust research designs. Now, I have to say that might be a slightly biased statement because one of the fellows who led the European research on multi-level suicide prevention was in this review group, so you know he probably has influenced that, but I actually think it's a fairly sensible statement. So the research really started back in the 90s with the US Air Force, so it was a closed system. What they did was to adopt 11 strategies with a focus on reducing stigma around suicides to increase help seeking, early identification and intervention. They had strong leadership involvement, whole of population education as well as health professional education, improving mental health services, making sure they have a surveillance over what is happening with the suicides and the suicide attempts. And one of the critical factors, I think, was identifying the periods where people in the Air Force would have been at risk. So disciplinary action was one of the times when people would have been at risk because they felt like their livelihood, their status was under threat, yeah? So they actually put in supports around some of those critical periods. And interesting, what they found was, compared to a baseline control period, they found reductions not just in suicide, but in domestic violence and in homicide. And I think that speaks to some of the common risk factors that underpin a lot of these difficult, complex behaviours. The research coming out of Europe started in Germany, in Nuremberg. It started as the Nuremberg Alliance Against Depression, became the European Alliance Against Depression, which is the model you can see there on your right. And their first trial in Nuremberg found a 24% reduction in suicidal behaviours. That was a combination of deaths and attempts. After 2 years of implementing this framework in Nuremberg, they also found that light touch continuation of those strategies maintained those reductions. So you don't have to do the full implementation going forward, you just need this kind of light touch, we think. And those reductions were compared to a control region. There was another trial in Hungary which found similar results and compared it to both a control region as well as the whole of the country. They then did a couple of subsequent trials in Europe where the findings were a bit more mixed, and that's kind of been the picture ever since. So there was a trial of a similar model in Japan where they found that it was effective in a regional or rural area but not in an urban area, and that they had greater reductions amongst men and older people. New Zealand, they ran a similar trial. In reading through their papers and talking to the investigators, what we think has happened there is that it was under-resourced. This is quite a resource-intensive kind of thing to set up. It didn't have long enough. There wasn't enough uptake, so the dose wasn't there, and they didn't find an effect. So it's difficult work to do, as I've discovered. So this is the work that we're doing. This is the Lifespan Suicide Prevention Framework. So you can see that it's a combination of both universal, selective and indicator strategies. So universal would be, oops, sorry, I keep hitting the wrong button. The means restriction, the media reporting, engaging community to respond to risk. And then the high-risk populations are targeted in improving emergency and follow-up care for suicidal crisis, using evidence-based treatment for suicidality, and then working with GPs to identify and manage people who are at risk. Frontline workers, so ambulance and police has been an area where we haven't been able to get much traction, but we thought it was a good idea. The school-based programs we talked about, and then the gatekeeper training here. So the idea is that we're building a community safety net, because if you just work with community and encourage help seeking and the health system isn't there to back it up, you actually risk an increase in suicide deaths because people disengage from help seeking, and we don't want that. So one of the things we're looking at is, are we getting both, if we implement these things all at the same time within a region, do we get both synergies but also catalytic effects? So an example of a synergy might be, so one of our regions, for example, did a big media campaign around people who had survived a suicidal crisis and gone on to seek help, so stories of hope and recovery, and then link that into the community. Oh, gosh, I'll get this right eventually. The gatekeeper training. So what we saw was that people responded to that call for action. They went off and they did more training. Yeah. A catalytic effect might be when we rolled out the Youth Aware of Mental Health program in high schools. The school counsellors and teachers said we need training to be able to support these students when they're identified as being at risk. So we developed a program called Youth in Distress, and we've had quite good uptake of that amongst school counsellors and school teachers, so they know how to support their students. So 9 strategies across sectors. There's an awful lot of data, so we've got coronial data, we've got ED data, we've got ambulance data, we've got admitted patients data, doing lots of research around this, but also using those data to provide what we're calling a suicide audit to each of our regions, which helps them to plan their means restriction activities, but also which sectors of the community are at risk. Because what we're finding is there's quite significant regional variation in patterns of suicide and the demographics of those who are dying by suicide across the 4 different sites. Okay, 4 trial sites plus 1. So let me get the button right this time. So our first site is Newcastle. Second site to go was Illawarra Shoalhaven, so this area down here. Third site was Central Coast, so Gosford and Wyong, LGAs, and then parts of the Murrumbidgee. So Murrumbidgee is fairly large. It's a very different area to some of the more urbanised populations on the coast here. So this was funded, initially it was a scoping study, which is what Michelle Torrick came over to do, funded by the New South Wales Mental Health Commission. And then we were fortunate to receive quite a large grant of almost $15 million from Paul Ramsay Foundation to actually implement this in 4 sites across New South Wales. And actually our first 2 trial sites, Newcastle and Illawarra Shoalhaven, have just wrapped up their 2-year implementation phase. We're celebrating this afternoon, so I'm running away from this to go and have some drinks. I was about to swear, I won't. But geez, it's been hard work. So we're quite excited that that we've managed to get through. It was a really difficult first couple of years, but it's come together. Those sites put in an expression of interest, and the criteria for selection were around: did they have the right population size for us to be able to detect an effect? Were they in the top quartile in terms of suicide attempts and deaths? And also, were they able to, did they already have an existing collaborative group who could work together across sectors, or could they at least pull it together? So those were the selection criteria that we used, and that's how we came up with the 4 sites. 2 sites are led by local health district, 2 sites are led by the primary health network, and we're seeing some interesting differences in how it plays out according to who's leading. ACT Health came on board last year. They weren't randomised, so we have to think carefully about how we include them in the analysis, but they did want to come on board as a high fidelity trial site, and you'll understand what that means when I flick to the next slide, I hope. Slide after, maybe. Okay, so we're using randomised step wedge design. That actually came about through conversations with Anthony Shakeshaft and others here about what might be the best research design. Cluster randomised control trial looked like it was going to be too difficult to find good control sites, but also to find enough control sites, too expensive to do because we would have needed many more control sites. We didn't think it was feasible. So this seemed like a good option. So what we have here, this yellow period is our baseline data collection for suicide deaths and attempts. This little light coloured period here is the planning phase for each site. This is the 2-year implementation phase, and then we'll be looking for data up to the end of 2020 to see whether we can detect a change in over time in both deaths and attempts. So yeah, each site was randomised to a different starting point. And what we hope to see is a decline in suicides that coincides with the implementation phase. This is the slide I was talking about. So the green dots there are our 4 New South Wales high fidelity trial sites. This is ACT. The red dots here and the blue dot here represent sites that are trialling multi-level models of suicide prevention, but with differing levels of fidelity. So what happened not long after we launched our trial was that the federal government decided they wanted to trial a similar approach in 12 primary health networks, and the Victorian government decided they wanted to trial it across the whole of Victoria as well. So while we're scrambling to set up the trials, we also got contracted to provide implementation support to these other sites. But they're not high fidelity sites, so they've got a lot more freedom in terms of what they choose to do and what they choose not to do. In the high fidelity sites, we have the focus on using programs that have got a really good evaluation sitting behind them. The other sites don't have to do that. It's not part of their contract, it's not part of their KPIs. So there are evaluations sitting around both of those different types of trial sites. So Victoria is being evaluated by the Sachs Institute, and the national trial sites are being evaluated by a team at the University of Melbourne led by Professor Jane Purkis. So lots of activity going on in Australia around suicide prevention at the moment. Yeah. So I just want to go through what's happened so far in the lifespan high fidelity trial sites, including ACT. We talked about that notion of having good aftercare in place. So 4 of our 5 trial sites now have a dedicated aftercare service in place for people who present to the ED, either, depending on the site, having made a suicide attempt. In some sites they include people with suicidal ideation. We've trained about 7,000 community members in gatekeeper training, 10,000 students in the Youth Aware of Mental Health program. So that's all Year 9 students across all trial sites in public schools, as well as some students in private schools. Lots of health professionals trained. We have a Step Care digital screening program that we're rolling out in general practices. And as I mentioned, we've got this suicide prevention intelligence system that we've set up to provide audits and to do the evaluation. There are other things we've done around rolling out Mindframe media training. I want to come back to that actually. So, yeah. Yes.
In my experience.
Yeah.
What does that look like in terms of when it's done well?
Yeah. That's a great question. We just finished a Sachs rapid review on that actually, on what are the components of effective aftercare. So I mentioned before that assertive aftercare, where it's the care provider who's responsible for maintaining contact, so it doesn't rely on the patient kind of going, oh yeah, I've got an appointment, I might turn up, and I might not make another appointment, etc. Rapid follow-up, so within 24 hours of leaving the emergency department. Follow-up that's flexible and adaptable, so it doesn't rely on the person coming into a clinic. The first contact might be made either in the ED or it might be made at the person's home. There are characteristics of the person who's providing the care, so that therapeutic alliance is really important. What are the other things that came out? They're probably the main things. And also the integration of non-clinical care with clinical care. By that I mean a program that can address broad psychosocial goals. So not just the mental health problems that people might be experiencing, but housing, finance, relational, family, etc. Yeah. So they're probably the main things. There is a service that's been set up by Beyond Blue called the Wayback Support Service. They've been funded to the tune of about $38 million to roll that service out in more regions across Australia, and their model is very much based on those kinds of principles. So, yeah. So media. Whenever you see reports in the media about suicide, they tend to fall into one of 3 groups. One is experts standing up and saying how awful the suicidal crisis is. That's not helpful. The research backs it up. There's a fellow whose name I can never pronounce, he's about 10 syllables, but based in Austria, who's done some work on what he calls the Werther effect and the Papageno effect. And the Werther effect is around the contagion effect. So if we talk about high profile people who've died by suicide, if we talk explicitly about the means by which they died, we glamorise their death, we sensationalise it, we increase the risk of contagion. We've seen that with Robin Williams' death. They looked at the increase in suicide deaths that occurred after he died, and it was actually amongst the biggest group was amongst men who were a bit younger than him. So there would have been men who grew up with him and who identified with him. Same with 13 Reasons Why. Again, we saw increases in presentations to emergency departments and calls to helplines, particularly amongst young women. So we know when we glamorise, sensationalise, we talk about specific means, we talk about specific individuals, that we increase the risk. So that's the Werther effect. That's the Werther effect comes out of a story. It's a novel called The Sorrows of Young Werther. Yeah, good. I got that right. The Papageno effect is based on a character from an opera who went through a suicidal crisis but found an alternative to killing himself, basically. And so it's this idea that if you put out stories about people who've been through a crisis but they've found a way through it, that you actually encourage help-seeking and more positive behaviours. And again, there's some kind of epi-research around that which seems to support those findings. Australia has led the way in developing what they call the Mindframe guidelines, which encourage safe media reporting, which includes both of those things, but also the inclusion of a helpline at the end of every media story, et cetera, et cetera. So just wanted to come back to that. We did, look, I have to say it was a bit of rough modelling around the impact of what the impact of each of the strategies might be. These models are only as good as the data you put into them. The data around the effectiveness of each of these strategies is a little bit limited. But what we found was that in terms of reducing attempts, crisis and aftercare seems to be the one where you're going to get the biggest impact. In terms of reductions in deaths, it's really working with GPs and health professionals where we're going to see reductions. But I think this probably reflects actually just a lack of good evidence, because I think there's probably other research which shows that this will also reduce suicide deaths. Yeah. And actually, it wasn't just our group that did that research. There was a fellow by the name of Andrew Page, who some of you might have come across, who also did some research and found similar sorts of findings. So I just want to wrap up on, oh gosh, I've talked a long time, haven't I? Sorry. So I'll skip through this really quickly. Primary outcome we're looking at is reductions in suicidal behaviour. Secondary outcomes are changes in suicide deaths. We chose that as a secondary outcome rather than primary, simply because of the time lag in coronial data. And then we've got a number of studies which are set up around this idea of trying to measure what's happening within each of the strategies. So there's community research that's going on. We're looking at the impact of the health professional work that we're doing, including experience of patients coming out of the ED. There's some work around improving crisis and aftercare going on, an evaluation of YAM, and then we're doing also an implementation evaluation to identify not only what was done and what was the impact, but how was it done, because in talking about what could we learn about lifespan and how it was done and what were the lessons, one of my staff said, the lesson is no one should ever try to do this ever again. And she was kind of right, because actually we've made a lot of mistakes. We've done a lot of things we wouldn't do again. So if we don't learn from that, we don't capture that so that the next group of people who want to do this or tackle another complex problem, then I think we've kind of missed the point, half the point of doing this kind of work, because you actually need to document and publish this stuff around not just the what and what the impact was, but how do we go about doing it and what do we learn from that. I think that's probably me done. Yeah, that's just the expected timing of the results coming out of lifespan. So thank you for being an engaged and interested audience. Great to be back.